Assalamualaikum and a very good morning to everyone. Welcome to this Breakfast at UMHealth webinar. I'm Rozita Abdul Malik, Clinical Oncologist from Clinical Oncology Department, University Malaya Medical Center, and I will be moderating this first session. The topic for this morning is on in vivo rectal dose measurement during HDR gynecological brachytherapy treatment in University Malaya Medical Center. For everyone's information, brachytherapy is one of the important components of radiotherapy in the treatment of gynecological cancers, and rectum is one of the important organs at risk during this treatment. It is my pleasure to introduce to you Dr. Zulaikha Jamalludin, a medical physicist from Medical Physics Unit, University Malaya Medical Center, and she currently serves the Medical Physics Unit and also Oncology Department, UMMC. She received her PhD in Clinical Oncology Physics early this year from Faculty of Medicine, University Malaya. And she joined us in 2010 as a clinical physicist and is responsible in producing good quality radiotherapy treatment planning for oncology patients, perform dose measurement and QA check for radiotherapy. Her main expertise and research activity covers all applications related to brachytherapy, SBRT, in vivo dosimetry, and hybrid treatment planning. And without further ado, I would like to welcome Dr. Zulaikha to deliver her talk.
Okay, thank you, Prof. Rozita, for the kind introduction. So I will start sharing my slide for today. So again, good morning, everyone. And I'm Zulaikha, medical physicist from Medical Physics Unit and Oncology Department, UMMC. So for today's talk, I will be sharing our experience and work on rectal dose measurement during cervix brachytherapy treatment. But firstly, I really would like to apologize because there will be a lot of technical terms related to physics, and please bear with me for the next 20 minutes with these terms. So let me start my presentation for today with a brief explanation of what is brachytherapy. So radiotherapy treatment can be divided into two types of radiotherapy, that is brachytherapy and external beam radiotherapy. So brachytherapy is a radiation treatment technique in which a radioactive source was placed directly either within the tumor or on the tumor surface or within a tumor cavity. So the radioactive source usually was left to irradiate the tumor or the tumor cavity for a calculated time or days until the tumor has received the intended dose. So brachytherapy, also known as internal radiotherapy. So this is in contrast to external beam radiotherapy or EBRT, whereby the radiation treatment in EBRT make use of high energy X-ray beam, which is directed towards the target region in order to deliver the intended dose. So in UMMC, we offer brachytherapy of the endobronchial, the skin, and also for keloid radiotherapy treatment. But the most common brachytherapy treatment in our department is the intracavitary cervix and vaginal brachytherapy. So our works or the presentation for today will focus on dose measurement during cervix brachytherapy treatment. So let's go into detail on cervix brachytherapy dose measurement. So here in UMMC, all patients were treated with definitive radiotherapy, applying an EBRT treatment with 48.6 gray of dose in 27 fractions for about 6.5 weeks of treatment. A total of 3 to 4 fractions of brachytherapy treatment were administered at week 4, 5, and 6 of EBRT to give a total dose of 80 gray to the tumor volume, while at the same time limiting the dose to the important organs such as rectum, sigmoid, and a bowel dose to less than 75 gray, and the bladder dose to be less than 90 gray. So this treatment regime following the recommendation from the Gynecology European Society, the ICR reject Istro, and also the guideline from the American Brachytherapy Society, the ABS 2017. So both guidelines recommend these dose in order to achieve more than 85% local control at 3 years' time and also reducing the organs toxicities resulted from radiotherapy treatment. So you can see that we are delivering a very high dose in each insertion during a brachytherapy treatment, that is between 7 to 8 gray per fraction. So this is what we call as a high dose rate brachytherapy. So to understand the motivation or the needs to perform the dose measurement during a brachytherapy treatment, we need to understand, or at least have an idea or overview of the whole cervix brachytherapy procedure. So each brachytherapy procedure is performed under spinal anesthesia in the lithotomy position. And when there was a failure or contraindication to spinal, the procedure will be performed under general anesthesia. So once the anesthetic team has prepared the patients, the oncology team will step in for the applicator insertion procedure. So a thorough gynecological examination will be performed first. And the length of the uterine cavity will be measured from the uterine sound in order to determine the length of the applicators to be inserted into the cavity. So applicators is actually a long, thin metal tube with closing end used to hold the radioactive source within the uterus. So once the applicators have been inserted, the applicators will be stabilized by using the gauze packing soaked with acrylflavin emulsion. So this gauze packing is very important to secure the applicator position within the uterine cavity, and also important in order to push the bladder and the rectum organs at a distance away from the applicators, so to reduce the radiation dose to these organs. So once it is done, the patients then will be transferred to a CT simulator room for volumetric image acquisition, in which these images will then be used for planning of the brachytherapy treatment. So during this treatment planning, the tumor and nearby organs at risk will be identified and delineated by the oncologist. And the intended dose planning of the target volumes and also acceptable organ dose will be calculated by the medical physicist. So once the treatment plan approved, the plan will be sent for treatment execution. And the applicators will be drawn out of the patients once the treatment completed. So of all these steps, the probability of dose inaccuracy or errors in a cervix brachytherapy treatment may come from these procedures. So major errors in intracavitary brachytherapy mostly comes from two events. So the first is in the event of applicator or source displacement, in which this will result in higher dose delivery uncertainties to both the tumor and organs. And the second one is due to human error or malfunction of the treatment delivery system, which these can result in a major disaster and will be categorized as major medical events. So due to the possibilities of these events, there are highly chances of what we have planned to deliver, the intended dose will not be the same during the treatment. So let's have a look at how does this happen. Applicator displacement is an event whereby the applicator or the source is being displaced during the treatment and it is different from its original location during simulation. So assuming that this red ball is the source which has been planned to be located at this point within the applicators. So if the applicator is not secured properly within the patients, the displacement will cause the source to be displaced at a different position from the planned position. So how does this impacting the dose and treatment accuracies? So let's have a look at this figure. So by placing the brachytherapy source along the applicators, so this producing line of doses, covering the whole uterine with the intended dose. So you can see that the treatment was planned to deliver 6.8 gray to the uterine cavity, as shown by the orange line, while some of the lower doses, such as the 5.5 gray, which represent 80% of the prescribed dose, will be splashed onto small part of our bladder organs, while maybe only 40% of doses fall onto the rectum organ. So now, if there isn't enough gauze packing to secure the applicators in its original position, this will cause the applicator to be slide downwards. So what happened is the uterine cavity will be underdosed, and the organs will receive higher dose than what has been accepted or approved during the planning. So for human error, the most possible event that can occur is selecting or importing the incorrect patient's plan. Assuming that this is the treatment plan for patient A, in which this is the intended dose to the tumor area. So if the physicist exporting the wrong plan, or the radiographer importing the patient's plan prior to the treatment of this patient, so these may result in a different delivered dose to both the target and nearby organs, such as in this example, causing overdosing to both the tumor and also to the organs nearby. And there also may be an event of network or computer malfunction, such as the stop button in the console did not retract the wire source, causing the source to stay in the exposure position within the patients, with resultant clinical consequences. So other possible causes of accidents in brachytherapy treatment can be seen from this table, as listed by the International Commission of Radiation Protection for user awareness. So it is obvious that these kind of errors will go unnoticed, and there are no ways to verify this except by measuring the delivered dose during a treatment delivery with the use of a suitable dose detector system. And also, this is part of assuring the safety and correctness of the whole brachytherapy procedure being implemented in our center, which can be achieved with in vivo dosimetry using a complete dose detector system. And this will help to quantify the differences between what have been planned and what was being delivered during a brachytherapy treatment for evaluation of toxicity. So now we go into the in vivo dose measurement. So in vivo dosimetry is defined as a dose measurement procedure performed during a radiotherapy treatment in order to know the true delivered dose and how accurate the planned dose is being delivered to the patient using a reliable dose detector system, such as in this example, the MOSFET, the OSLD chip, TLD chip, and the diode. So the American Association of Physicists in Medicine, AAPM Task Group 62, has described this as part of good clinical quality assurance radiotherapy program. So this is just an overview of those measurement works related to clinical services that has been conducted and performed in UM and UMMC, which can be found if you search for this website. You will see some of the works related to those measurements of the skin, the lens, and also in pediatric patients undergoing a CT scan procedure. So this is part of medical physicists' works in assuring the safety and proper use of radiation in medicine. So in brachytherapy, the in vivo dosimetry usually perform for dose assessment during breast to measure either the skin dose of both the ipsilateral and contralateral breast or the tumor dose itself. And also in nasopharyngeal carcinoma of brachytherapy in order to verify the tumor dose. And during the cervix and prostate brachytherapy for measuring the rectum and the bladder doses. And also the latest study which shown the success of those measurement during intraoperative radiotherapy or IRT of breast. So IORT is actually categorized as electronic brachytherapy treatment. So this table provides the summary of all published work related to clinical in vivo dosimetry in brachytherapy for various sites, including the dose measurement in gynecology brachytherapy, starting from the first study in 1999 and including the published study from our own group. Okay, so you can see that there's a scarcity of data pertaining to brachytherapy in vivo works in comparison to in vivo dosimetry related to external beam radiotherapy. And this is due to the declined use of brachytherapy practice in most of radiotherapy centers around the world, and also due to the search for suitable detectors for measurement in brachytherapy, because brachytherapy is characterized by its steep dose gradient region. So in our works, we use two types of dose detector. So the first one is the commercial diode detector, the PTW diode detector. This diode detector is specifically designed for rectal dose measurement, consisting 5 diode detectors in an array manner. So the second one is the newly developed detector known as Moskin. So this detector was developed by Wollongong University of Australia, and this detector is expected to produce higher accuracy of dose measurement due to the small and thinner detector active volume. But regardless of these features, what is the most important thing is these detectors were chosen due to the ability of both to provide real-time dose measurements, which allowing the treatment to be stopped or terminated at any time in the event of unexpected high dose or wrong doses being recorded in the system. And this helps to prevent further major errors. So in this work, we perform rectal dose measurement in 16 selected patients with total of 48 insertions. So during patient's preparation in each procedure, the patient's rectum will be deflated first in order to drain the gas that was trapped in the rectum. So this will help to place the detectors nearer to the rectal wall for a definitive rectal dose measurement. And the Moskin detector will be attached at the surface of the diode detector. And both detectors will be inserted into the patient's rectum to measure the dose delivered to the rectal, as can be seen in this simulation image. The in vivo measured dose from the use of diode and Moskin detectors will then be compared with the rectal dose calculated from the treatment plan. So this is the outcome of our measurement. So the rectal in vivo measurement with Moskin detector resulted in a lower average percentage dose difference in comparison to the commercial diode detector, as can be seen from this graph. But however, if this was translated into absolute dose values, the average dose difference will calculated to be only around 0.1 gray and 0.5 gray respectively. And based on the literature, we have seen that our study recorded a much lower dose differences between planned and measured doses in comparison to other studies. So what can we conclude from this measurement? So from the outcomes of the study, the equivalent range of Moskin rectum dose deviation between the planned and measured with commercial diode indicates the reliability of this Moskin as the detector of choice. And we also can conclude that we are able to deliver a correct and safe brachytherapy treatment to our patients. In each insertion, all trainees is well trained and did a good job in ensuring the applicators were properly secured throughout the entire brachytherapy procedure, starting from insertion until the treatment delivery. And also, we can conclude that correct plan was exported and being imported and go through proper check by both physicists and radiographers in charge. And plan was safely delivered. So the small dose deviation of zero point 0.1 and 0.5 gray is actually contributed by the anatomical changes from the transfer between patients' preparation room to simulation rooms and back to the treatment rooms, and also due to the detectors and the treatment planning system uncertainties itself. So now that we have already successful in measuring rectal dose during a cervix brachytherapy treatment, and we know now that both detectors are reliable as in vivo detectors, so we now would like to extend the use of this detector for other in vivo works. So we're planning to focus on dose measurement in bladder organs during brachytherapy treatment, since there is possibility of volume changes to occur due to physiological changes, and also due to different bladder filling at the time of simulation and also at the time of treatment. And also based on our experience, the vaginal stricture do occur in some patients as a result of external beam radiotherapy. And this vaginal stricture cause difficulties to insert gauze packing, which in turn causing the applicators to be placed near to the bladder neck. So it's worth to measure and verify the dose to this area by means of in vivo dosimetry. And future works also plan to find for any correlation between in vivo measured dose with the organ toxicities. And the findings will help to find ways to improve dose delivery and services in brachytherapy treatment. So as a take-home message, the in vivo dosimetry has been proven to be an effective method to verify the whole chain of process in brachytherapy treatment, starting with patient preparation until the end of the treatment. So with support and cooperation from all, we as medical physicists will continue to develop and implement new dose measurement techniques in order to improve the accuracy of clinical services for the benefit of our patients. So with that, I thank you.
All right. Thank you very much, Dr. Zulaikha, for the interesting talk. Okay. As has mentioned by Zulaikha, we know that brachytherapy is one of the important components of radiotherapy for gynecological cancer, and why it is important for us to make sure that the organs at risk receive a dose that is within the tolerance. So that is research work in vivo dosimetry for gynecological cancer. So Zulaikha, we have one question in the Q&A. Question is, how do you ensure, in spite of packing, that the metal used in brachytherapy stays put while the patient carries on with his ADL? Has there been any measurement to determine if these rods have shifted by the end of the course of therapy?
Okay. Measurement to determine if these rods have shifted by the end of the course of radiotherapy. So actually, this is the purpose of in vivo dosimetry, so that we can ensure that if there is any shift in these applicators. Okay, so at the same time, there are some centers that also are doing image guided at the end of the treatment. So we know that before the treatment plan, before the brachytherapy treatment, we do the simulation. So there are some centers that have the ability to get the fluoroscopy or to get the ultrasound in the operation theatre, in the brachytherapy room, so that they can verify the applicator placement. So we are moving towards that because right now we have received our new ultrasound machine, so that this is one of the future work that we are going to implement in order to ensure that the applicator are in place by the end of the course of the brachytherapy.
Yeah, apart from the packing, we also ensure that the alignment of the applicators during simulation and so before the start of treatment, we will check that before we start the treatment. So that also helps in maintaining the applicator positions, okay, and also by ensure the same bladder filling, okay, and so all this would in a way make sure that the dose delivered would be the intended ones. Okay, one more question. Is in vivo dosimetry a standard procedure in all the radiotherapy centers?
Okay, so the in vivo dosimetry is not a standard procedure in all radiotherapy centers, but it is recommended to be implemented by the international guidelines such as the APM, the ICRU. But as far as I know that most of the European countries, they have some of the radiotherapy centers has made this as compulsory. So because we know that they have some issues, some law issues with the patients, because so they make it as a standard in the radiotherapy centers. So if your centers or if some centers that have the ability to get a complete set of in vivo dosimetry system, so I would recommend this to be a standard procedure in the centers.
Okay, I think that's the question that we have. So I think I will conclude this session, and the next I will pass to Dr. Muhammad Ridwan from surgery. Thank you.
Okay, thank you.
All right, my name is Dr. Ridwan. I'm actually from the Department of Surgery in the Division of Plastic Surgery. I'm very honored today to introduce my colleague, Dr. Kwan, who has been with our team since 2010. Dr. Kong graduated from UNIMAS in 2002 for his undergraduate, and then subsequently completed his master's in surgery in 2010, and after that as well completed his plastic surgery training in USM in 2016. So today, without further delay, I would like to invite Dr. Kong, which will be presenting about fat. All right, so I would like to invite Dr. Kong.
Hi, thank you, Dr. Muhammad Rizwan, for your kind introduction. And also thank you for giving me the opportunity to share with you all something that we do commonly in our division of plastic surgery. Okay, fat is good. Okay, a lot of people don't like fat. Okay, you all don't want fat, right? But we can do a lot about, we can do a lot with the fat that you have. Yeah, nobody wants to be fat. Okay, everybody wants to get rid of the extra fat. It doesn't feel like everybody wants to be thin and that everybody is scared of gaining weight. What can you be done to your unwanted fat? So we do fat transfer. Okay, I'm sure some of you have heard about it. Okay, but we'll talk more detail about what can be done and then what we are doing about it. Okay, we just touch a bit on history. The transplantation of free adipose tissue has already become an old topic, with the first description in the year 1893 by Prof. Nubert from here in Germany. And then it developed until it peaked in the 1920s and 1930s of the last century. However, much of the knowledge gained was lost, and apart from a few pioneers, hardly any work was done using this method until recently. Okay. And only after the publication of results for breast augmentation using free autologous fat from liposuction by Sidney Coleman of New York in the year 2007, then the interest came back. And then now it's like a lot has been done on it. For the method of harvesting this fat, we use most commonly is liposuction. You have a few techniques, but the most effective method is using the water-assisted liposuction. Then we wash and separate it. Okay, what we want is a small chunk of adipose tissue, diameter less than 1.5 mm, which contains stem cells. Yeah, I'll talk more about it later. The adipose tissue also contains numerous factors which promote and support a wound healing and chronic pain conditions. Okay, because of this effect, then we can use it on a lot of conditions. And so, as you know, sources of stem cell, okay, the main one which we're talking about is the embryonic stem cell. Okay, however, to harvest it, to use it, creates a lot of ethical concern and also can invoke immune response. another source of stem cell is by induced pluripotent stem cell. Okay. However, to prepare this is very complex and time consuming. Okay, so it is not being utilized a lot. Okay. Then the next one will be the bone marrow derived mesenchymal stem cell. Okay, this one we can harvest, but it's painful. Okay, to harvest from patient, and the harvested cell use only low number. You can harvest a large quantity. Okay, so it's very limited, and then it's painful. So now we're talking about adipose derived stem cell. Okay, this from the fat tissue adipocyte. It's easily harvested by liposuction, okay, which we do very commonly, and it's abundant. You can get it. I mean, the more fat you can get, the more of this adipose derived fat cells. And then it can differentiate into cell types of the 3 developmental germ layer. It cannot go way back to the as good as embryonic stem cell, but it can still differentiate into the 3 main germ cell layer: endoderm, mesoderm, and ectoderm. Okay. So for harvesting this adipocyte derived stem cell, we use common aspiration technique of slight negative pressure, which is less than 250 millimeter mercury, with a syringe. This could harvest a large volume of adipose tissue. Okay. Another way to harvest is you can just excise. If you need just a small amount, you can just excise a piece of adipose tissue and then mincing it to tiny particles with blades. Okay, this one will obtain higher concentration of the adipose derived stem cell. Okay, because this one is less traumatic. Okay, so for liposuction, the adipocyte derived stem cell are more likely to differentiate into endoderm germ cell layer. Okay, and then also based on anatomical location, type provide a better yield of adipocyte derived stem cell than the abdomen, waist, and inner knee. Okay, so if possible, we start from the type first. Okay, so a few studies from tissue engineering which shows that the multi-lineage cells from human apoptotic tissue can be used for a lot of cell-based therapy. Okay, it contains this process lipoaspirate. Okay, can differentiate in vitro into adipogenic, chondrogenic, myogenic, and osteogenic cells in the presence of lineage-specific induction factors. Okay, so it shows that a lot can be done for these adipocyte tissues. Okay, also another paper published showing that the human adipose tissue is a source of multipotent stem cells. Okay, so the processed lipoaspirate cells can be isolated from human lipoaspirates, and like mesenchymal stem cells, it can differentiate into osteogenic, adipogenic, myogenic, and chondrogenic lineages. Okay, so these processed lipoaspirate exhibited and unique characteristics distinct from those seen in mesenchymal stem cells, including differences in the CD marker profile and gene expressions. Okay, also the adipocyte-derived stem cell shows considerable promise for regenerative medicine applications. Okay, so the adipocyte-derived stem cell contain this stromal cell, which also contain vascular cell, targeted progenitor cells, and pre-adipocytes. Okay, and then can get a large amount, and then we obtain it in less invasive way. And then we also perform it under local anesthesia, which is less painful, and then ensuring patient comfort. And then the extruded cells are easily grown in culture, and they retain their properties over many passages. Okay, so just to go back on the histology of skin, okay, as you all know, we have the outer layer, the epidermis, and then the papillodermis, reticulate layer of dermis, and then the adipocyte. So this is where we harvest the adipocyte cells, okay, at the subcutaneous adipose tissue layer. These adipocyte tissue-derived stem cells are not stem cells because they lack self-renewal capacity. Okay, like I say, it's not as good as the embryonic stem cell, but it can proliferate significantly, okay, to a number required for regenerative purposes. In spite of this, the adipocyte-derived stem cell can differentiate into different types of cells. For example, osteoblasts for bone, chondrocytes for cartilage, adipocyte, fat, pericytes, and smooth muscle cells. This adipocyte-derived stem cell increase the uptake rate and the survival of adipocyte cell after adipocyte tissue transplantation. Okay, as compared to the adipocyte which are sensitive to hypocell, this adipocyte-derived stem cell adapt easily to hypocyte react with a high proliferation rate. Then can produce and secrete a large number of growth factors, cytokines, and components of the extracellular matrix, which suppress the apoptosis and inflammatory processes and promote mitosis and angiogenesis. Okay, this one has been published a lot. Okay, so how we do it? We can do it under anesthesia and local anesthesia as well. Okay, and then plus a bit of mild sedation. Okay, due to the reduced sensitivity of the fat tissue. Okay, just now I show you the histology, the subcutaneous fat layer. Okay, is not that painful. Okay, as compared to other structure. Okay, there is no need to do a general anesthesia or a deep sedation. Okay, so we just anesthetize the surface layer to entry, for the perfusion cannula to enter into the fat layer. Then we can harvest it without much pain. Okay, just need local anesthesia and mild sedation will do. After introduction of tumescent technique, tumescent contains local anesthesia, adrenaline, epinephrine, and the bicarbonate. Okay, in a mixture. Okay, even large quantity of fat tissue can painlessly be removed. During the liposuction, the patient herself is the best warning system. Okay, so if you do it under local anesthesia, patient can tell you, okay, if you have breached the fascia or the muscle. Okay, so the patient will tell you, okay, to prevent the prevention of accidental injury. Okay, because the fat layer is relatively painless. Okay, so patient can tolerate, but if your cannula or your needle goes beyond that area, patient will tell you. Okay, because during the technically correct execution of the job, only the fat tissue is subjected to anesthesia. Any wrong entry of the needle will directly result in the patient crying out in pain. Okay, so this is a good warning system. For mild sedation, we just give initial intravenous milligram midazolam has proven to be effective. About half an hour, but it's enough. Okay, the perceptible reduction of the patient who is fully ready to cooperate can be easily achieved by this in the shortest period of time. Okay, so effective only like less than 30 minutes. Okay, is a bit short for our duration of operation. Usually will last about 1 hour plus, but it eliminates the initial fear factor and feelings of uncertainty. Okay, so patient will be sufficiently relaxed for you to do the procedure under local anesthesia. Additional verbal anesthesia, which means a constant communication with the patient, really contributes to a painless treatment. Okay, so this is how we harvest. Okay, we can use a machine. If you need a large amount, you can use machine. Otherwise, if just a small amount, you can just use a syringe with that negative pressure and aspirate the amount required, and then we can centrifuge it. Usually we centrifuge it, we got the centrifuge machine. Okay, and then we remove the oil layer, and then we also remove the aqueous component. We just take the middle part. We use a wick to remove the upper oil layer, and then we transfer the syringe to inject it. Okay, so this is another diagram to show about harvesting, and then this one also they proceed to isolate and then confirm the adipocyte-derived stem cell characteristic. Okay, after harvest, they digest with enzyme, centrifuge, then they take this stromal vascular factor and then culture it. Yeah, and then go through the flow cytometric analysis and to confirm it, the adipocyte-derived stem cell. Okay, but usually in our practice, we do not need to confirm because it's there. Okay, it's in the fat. After we harvest, we centrifuge, okay, at 1,200 G-force at 2 minutes, which delivers optimum survival rate of the fat cells. Okay, so after centrifuge, okay, so what we want is the middle part, okay, the fat for transplantation. We don't want the upper part, which we remove it, the oil, and then also the bottom part, which contains the cell detritus and oil emulsion. We let it flow down, okay, until all this is removed. Okay, so after centrifuge, this is the layer that you see, a 3-layer clean up after centrifuging. Then we remove the oil residue using cotton or wheat or paper. And then at the bottom layer, we release the stopper, and then it will flow out. We remove the aqueous base. Okay. Now I come to the usage of fat transfer. I told you the fat that we harvested contain the adipose-derived stem cell. Okay, we can use for a lot of things, which has been used already actually. And then some of it we are using in PPM. Okay, we do for face rejuvenation, facial deformity correction, hand lipofilling, breast augmentation, gluteal augmentation, bone regeneration, cartilage repair, myocardial restoration, scar tissue reconstruction, wound healing. Okay. Okay, so some are for reconstruction purpose, some are for augmentation purpose, and then some are for repair purpose. Okay, so you can apply for both reconstruction and also aesthetic indications. For face rejuvenation, okay, we can treat wrinkles, okay, by micro and nano fat grafting. So we just inject a bit, okay, nanoparticle of fat, okay, which will improve the skin quality by fat transmission and has been proven by many studies. You can see the wrinkle here. Okay. So another example, okay, this is a 28-year-old woman, okay, with a dark ring 5 years later. Okay, and then sometimes they need to do a few procedures. Okay, so usually we tell them that one time some will see the effect, and then some might need a few sessions. Okay, the good thing is it can be done under it can be done under local anesthesia, and then is relatively with little complication. Okay. And then also we should explain to the patient at the beginning, as in case of any fat transplantation, that in case they put on more weight, like more than 5 kilograms, the transplanted area will exhibit a visible enlargement. Okay, because the fat will grow. The fat, okay, that we injected, it will go with the patient because it contains the stem cell. Okay, compared to for those inject fillers, and a lot of the commercial fillers available which contain collagen, silicone, hyaluronic acid, it doesn't go, it will absorb. It won't last more than 6 to 9 months. Okay, so I have to inject again. But for this fat transplant, it will regenerate. Okay, because it contains stem cell. Okay, so tell patient that don't put on weight. If put on weight, the stem cell in the fat transplanted will put on more weight. Okay, so it will enlarge. Okay, so another example is rejuvenation at the jawline and neck. Okay, we place the fat along the border of mandible. You can see the significant enlargement of the lower lip. Okay, so another example. Okay, this patient had fat grafting at the lower face. Okay, we injected 15 cc to chin and then 12.5 cc to the left border mandible. So as you know, aging process, patient will go the face atrophy. Okay, there's a global facial volume loss. Okay, so we can do a full face fat graft, okay, using total of 63 mils of fat. You can see a difference. Okay, so there is a patient with a non-secreting papillary adenoma through a craniosacral incision. So we injected 9 cc of fat, okay, at the temple depression, and then another 70 cc into the scalp behind the hairline. Okay, you can see the obvious restoration of the contour of the temple. Okay, and then also can inject to the hand. Okay, I do the hand rejuvenation. Can inject. Okay, aging process of the fat goes atrophy, so we can transplant the fat. Okay, and then to smooth out the finger tendon line. Okay. So it's done for facial deformity like this syndrome, Tracheocolin syndrome, okay, where there is a depression after patient underwent surgery, okay, plating for the zygoma. Okay, you can see the extrusion of the hardware and the zygoma. So fat grafting is done from the lateral lower eyelid extending out to the zygomatic arch. Okay, so this reinforce the thin lateral eyelid skin and also covered the obvious hardware visible through the thin cheek area. Okay, also there's a patient with facial atrophy with the primary involvement of the left side of the face, can inject it. Okay, and then it will restore the volume. Okay, so like I said, one session might not be enough. Okay, because we cannot inject too much fat because the fat need good blood supply to survive. Okay, so we inject. Okay, so in the beginning was a patient. Okay, this procedure might need a few sessions to achieve the desired result. Okay, so this patient second procedure injected and then we stop the result already. Okay, now we come to the aesthetic breast augmentation. Okay, so we can inject 200 to 300 ml per breast. Okay, we assume there is no 100%, like the fat not all will survive. Okay, so we take about 60% survival rate generally. After healing, this corresponds in case of average grafted volume of 250 ml to an volume gain of half the cup breast size. Okay, so patient should tell you what cup size they want, so we can estimate how many sessions is needed. Okay, so we plan accordingly. So besides breast, we can augment the gluteal region. Okay, so indication after heavy weight reduction, or if the person is not satisfied by the shape provided by nature, or for any acquired or heterogeneous defect, capsular fibrosis after previous silicone implantation, or for scars post-surgery. Example, this patient had a S-gap flap harvested, a superior gluteal artery perforated flap. Okay, so after the flap harvested, the area is thin out, and then this is a weight bearing area. Okay? The patient said it be painful because of thin out skin, so we injected fat. Okay, this about 290 cc of our own fat. Okay, and then only one session, the patient fully cured of her pain. Okay, and then beside that, there's also visible optical improvement of the scar. Okay, so it looks more symmetrical. For gluteal augmentation, okay, the position we can harvest from the thigh, abdomen, and knee. Also, we can harvest from the sacral region. So for gluteal augmentation, the easiest to harvest from the sacral region because patient in the prone position. You harvest as a side, okay, from the sacrum, and then inject, okay, to the gluteal. Okay, after processing the fat, okay, and then we put a sponge gauze dressing at the sacral region. Okay, and then all the fat transported area, no pressure. Okay, the patient that must avoid pressure at all costs. Okay, because after injected, the fat is still mobile. Any pressure will displace it. Okay, so patient must be prone. So for this case, patient must be lying prone, okay, for 1 month for the fat to stabilize. Okay, so another example. Okay, some place they like this Brazilian butt, American countries, Southern Europe or Africa. Okay, so the ideal ratio of waist to hip lies at about 1 to 1.5. Okay, so we can achieve it, okay, by the fat transplantation. Okay, now come to another commonly used what we use the fat for. Okay, for the scar. Okay, for scar, as you know, is thick and then it's adherent, so it's hard. Okay, so patient will be not comfortable, okay, because it's pain, and then it doesn't slide, okay, and then it'll be pulling on movement. Okay, so we harvest it and then we inject it under the fat. We injected the fat under the scar. Okay, we release the adhesion first. So the scar is adherent to the underlying tissue. We release it. Okay, and then we inject the fat to restore the plasticity of the soft tissue and the skin. Because the fat tissue will provide a sliding mechanism, okay, for the skin movement. Okay. So to release the scar from the skin, we use the 14 gauge needle, okay, to break through the adherent scar. Okay, you can use a sharp needle or a blunt needle. The blunt needle we have this Toledo dissector. Okay, some area we need a sharp needle, some area just use a blunt needle to extract it, and then we infiltrate. Okay, we have this needle, okay, to the area that we want. Okay, it got different sizes. Okay. So example of hypertrophic scar at the forehead, okay, before and after subcision and fat grafting. Okay. So another example of scar tissue, in order to reduce the danger of infection or perfusion, the mostly scar affected and thus fragile skin must be damaged to the least possible extent. Okay, so we need to maintain the vascularity. Okay, for this patient, the subdermal scar formation after hematoma of the scar tissue it so show that after the lipofilling, the scar dissolve. Okay. So another example, this patient had a latissimal dorsi plastic surgery harvested, so that be dimpling scarring. Okay, so patient have pain due to the inherent scar. So I show you, we release the scar, lysis, then injected the fat underneath. Okay, restore the contour. So patient free from the fat after two procedure. Okay, sometimes need a few procedure. Okay. So we also do fat transfer to wound. It promote wound healing. Okay, because of the stem cell inside. Okay. So the method described is this DELT method by debridement and autologous lipo transfer. So example, this patient with a chronic wound for 12 months already. So after debride and then apply the fat on top and then skin graft and then it heal. Yeah, so also can be treated for diabetic foot ulcer in the 74 years old. This patient, as you know, difficult to heal, especially when they have chronic renal failure and then post amputation with the neuropathy and then the peripheral vascular disease. So this example is debridement done and then apply fat on top and then it heal. Okay. So this method show that after debridement of the wound, we transfer the fat into the wound and the wound healing base using sitting gauge needle, and then the fat will promote the healing. So a lot of examples like chronic wound. Okay, after debridement, transfer the fat and then it heal and then we can apply a skin guard on top. Then after this one about 3 weeks, it heal completely. For fat transfer to wound, we require about 2 mils of fat tissue per square meter of the base are required. Okay, so for this example, patient with the diabetic foot ulcer, okay, which lasted for 19 months, okay, after injected 8 mils of lipo of the fat, okay, achieve wound healing over a period of 10 weeks. Okay, so we have done it for our patient with a breast carcinoma. Okay, it's a fetal tumor H1. After mastectomy, okay, the wound bed is big, and then some are gonadine, some are not. So we apply fat transfer on the wound bed, and then vacuum dressing, negative pressure therapy, and after it completely granulate over the fat graft, and then apply skin graft, and then it all taken, and then it heal. Okay. Another patient herself with a wound at the foot. Okay. There are some areas of the tendon exposed, as you can see. So we apply fat transfer, okay, and then 1 cycle of vacuum dressing, and then skin graft, and then all taken, okay, and then it heal completely. Okay. The study show the wound healing and antioxidant effect of adipocyte-derived stem cell, okay, mainly mediated by the activation of the dermal fibroblasts and keratinocyte via the biochemical mechanism. Okay. Since adipocyte-derived stem cells are easily obtained in large quantity and have an advantage over other stem cell sources, so these are now being widely applied. Okay. So we have done we have done our study in PPUM on patient after breast conservation surgery with a deformed or retracted scar, or after autologous breast reconstruction. There's the contour of volume disappropation. Okay. And also on patient with a benign breast lesion after excision biopsy, you end up with asymmetrical breast. Okay, so these are the example of the patient before the fat transfer. So we calculate, estimate how much fat we need, and then we harvest. Then we mark the donor site. These are the equipment that we have, that we use. We all the cannula applicator with the lipo collector. Okay, these are all the liposuction tubing, the cannula. Then we have the machine. We use the water jet assisted liposuction, the wall system. In liposuction, there are a few systems. Okay, one is power assisted, ultrasonic assisted, laser assisted, but all that are harmless. I mean, sorry, all that are more harmful to the fat cell. Okay, so we prefer to use water assisted, okay, which will have better survival of the fat cells. So this is how we harvest. Okay, there's a pulsating jet, the 30 bar, 90 mils per minute at 30 degree angle. Okay, the negative pressure is 0.5 bar. Okay, there's a simultaneous action of suctioning and the gentle movement. Okay, like this. So we had a corridor hydrogen generated in a fan-shaped pattern. So we harvest over the area that we want. Okay, harvest. Okay, after harvesting, we process it. So this is our equipment. We remove the contaminant, preserve the quantity of the adipocyte. Okay, this processing will have less apoptosis and greater angiogenesis, the highest concentration of intact and viable adipocyte. It's a very gentle way of processing. We go through this lipo collector. Then we wash it with Winger's lactate with buffer solution 3 times to achieve a physiological normal pH and osmolarity. Okay, so after we leave it, okay, and then also centrifuge, you can see the layer. Okay, the fat will go up, and then the fluid and the cell will go down, and then we remove it by removing the stopper. Okay, and then after we process the fat, we transfer to the area one. Okay, like the breast. Okay, after we made the marking. Okay, so for injection, we cannot inject one big chunk. Okay, we need to inject small droplet of fat. Okay, in this direction, the fan shape. Okay, so that the fat will survive. Okay, so it is a 3-dimensional fan shape injection. Okay, inject periglandular, subdermal plane 2/3 and intramuscular plane 1/3, which vascular plexus. Okay, so the fat must be in contact with the vascular tissue in order to survive. So our study, we use magnetic resonance imaging (MRI) to measure volume before and after this fat transfer. Okay, we had a stem radiologist to read the MRI, and the radiologist is blinded to the result of transfer volume. So the radiologist doesn't know how much volume we transfer. Okay, so these are the results on patient. So the mean volume increased. Okay, initially about 436. Okay, and then after 1 month, it increased. Okay, so we can assume that the stem cell has regenerated. Okay, and then after 6 months, it shrink a bit. Okay, maybe some of the fat atrophy, but the volume increased. I mean, the fat retention is there, 93.6%. The other study show about 60%. So our study show 93.6%, which is good. I mean, which is better than other study. And then also, for this patient, there's no serious adverse effect observed throughout follow-up up to 6 months. So this is a graph. Some reduced, but statistically mostly increased by 93%. There's a mean fat retention at 6 months at 93.5%. So the absorption is 6.5%. So this result better compared to other clinical report outcome. Others reported 40 to 60%. So these are the images of our patient. Some of our patients. Okay, this patient, there is a white breast defect. It's a 40 years old lady. present with depressive scar at right upper quadrant. 3 days after injection of 76 mL of washed autologous fat graft, you can see there is a restoration of the volume. And then 6 months, it remained. I restore the volume, then it become permanent. And then there's also increase by MRI quantification, and there's 113% of the fat retention. So it not only retains, but it regenerates. It's the fat grow. Okay, compared to like inject fillers or something else, it will be absorbed. Okay, it won't regenerate.
Dr. Kong, it's already 9 o'clock, and we have several questions from the attendees.
Oh, okay. So I just finish off the images. Okay, so this this is another patient. Okay, the left breast deformity. Okay, after injection. Okay, and then there is a volume retention of 332%. This is another patient as well. Autologous reconstruction. Okay, we injected 27 mL fat. Okay, and 6 months later, there's an improvement. Okay, it's more 288. Okay, we cannot explain how it regenerates up to 288, but we assume it's due to the stem cell inside the fat transferred fat cell. Okay. So my last slide. Okay, so a lot of people will ask whether it's safe or not, worry about breast cancer. So there are many studies, okay, shows that there's no evidence of increased oncology risk, and also there's no primary cancer cell in healthy breast reconstruction we are profiling. Okay, there's no increased risk of local regional recurrence, systemic recurrence, or second breast cancer. Okay, so it's a very safe technique because we transfer patient own. This fat is patient own fat. Okay, it's not somebody else. It's not some synthetic material. So it's very safe. So only that if you want to do like the mammogram or ultrasound, so the radiologist might be familiar. Okay, that the patient history of fat transfer, so they know how to differentiate. Okay, whether is it a fat or something malignant.
Okay, Dr. Kong, is it okay if you proceed? Because it's already 9 o'clock. Right. So the question is by Prof. Chan Yu Kwan. She is asking what is the risk of infection for this procedure, and if the second question from her is that if the person is very thin, has no fat, where can you get fat, the donor fat?
Oh, okay. I'll answer the first question. So far from our experience, from our study, we don't see any infection. We don't see zero from our experience, from our audit. Because we done in OT, you can see all under sterile technique. So there's no zero infection.
So because we did it on under sterile technique to be done, isn't it? We did it under sterile.
Yes, we did under sterile technique in OT.
Right. So the second question is if patient very thin, no fat grafts, so where do you get the fat from?
Oh, okay. It must be the same patient, okay, or identical twin. Okay, cannot be somebody else, okay, because if it will go a lot of rejection, okay, if somebody else, so must be the same person or identical twin. So what we do is we harvest a few sessions. Okay, I say we cannot one session. I mean we won't tell patient that one session can achieve what is desired. So we can one option we can split a few sessions. Okay, so ask patient to maybe harvest first, and ask patient to build up weight, and then harvest again. And then what is we do the centrifuge, and then we get more of the fat tissue. So that's how we achieve it.
Okay, so is there one question from the attendee asking, is any contraindication for this fat transfer? Any contraindication for fat transfer? Contraindication.
So far, in general, there's none, but it depends on the patient condition. Okay, for example, those who have, like our study, the breast reconstruction. Okay, so our contraindication is those with a recurrent disease. Okay, recurrent disease or still undergoing chemotherapy, radiotherapy. That's our relative contraindication. Okay, so it's not a general consumer. It's a patient specific contraindication. Okay, Ridwan,
Another question is there any risk of fat necrosis or fat embolism in this procedure?
Okay, fat necrosis, yes, there's a risk. Yeah, there's a risk. Like I say, we injected a small amount. Okay, we don't inject a big chunk of fat. Okay, a big chunk of fat, so the fat will survive, but the inside part will not survive because there's no blood supply. Okay,
And then we
so
give it
it's it depends on technique. And then
and
fat
it's about
embolism.
60%, right, isn't it? 60%
Yes,
fat
60%.
intake, right, isn't it? We
60%.
right.
Yeah. So 40% will necrose, but the body will absorb it. Okay.
Yeah.
For
Then the
fat
fat embolism,
in a big chunk, small amount. So what our experience, I would say also there's zero fat embolism. Okay, because very small amount. So and then also we avoid blood vessel. You can see all the fat. There's no blood. I mean, we don't see any bleeding. We don't see any red color. So that's to ensure that it doesn't go into the blood vessel. So it's very safe. I mean, also another thing is the surgeon technique. Surgeon must be well qualified, okay, to know the correct technique, the correct anatomy, the correct layer.
Right.
Is liposuction therapy for weight
exactly.
loss?
So I put this question as the last.
Available.
Is liposuction for weight loss available in UMMC? I think the second question you answered already. Only for autologous transfer, right? Answer.
Yeah, autologous.
So I put it at the last. So would you like to answer that, Dr. Kwan?
Yeah, weight loss liposuction for weight loss available. Okay, means someone fat, so we can do the liposuction to remove a significant amount of fat, okay, so that patient lose weight. Yes, it's available. Yeah, there's a common liposuction. We patient to reduce weight, so we do liposuction. So this liposuction is throw away. Okay, we suck out the fat, we throw away.
So apparently, what you're trying to say is the patient has to lose some amount of fat first, right? Is it with fat loss, either bariatric surgery or fat loss or weight loss? Then the resistant fat, isn't it? The resistant remaining fat is actually used to remove is removed using a liposuction technique. Right?
The residual fat. Okay. And then this is what we commonly do. Okay, after patient lose weight or patient want to reduce the weight, so we suck out the fat, okay, throw away. So, but now we go a bit further. I mean, we go one step further where we process the fat and then we inject. As a fat transfer.
So, but
for this,
whether it's available in UMMC, I think most of this procedure, I mean, if you want to do liposuction for weight loss, it's mainly done in UMSC, Dr. Kong.
Yes, because now our OT is limited. Our OT slot is limited because we do in OT. Okay, we don't do in clinic or bedside. Okay, it's all done in OT, sterile procedure. So the limitation is the OT time.
Okay, all right. So I would like to thank Dr. Kong for the very good explanation on lipofilling procedure. So we can know that and answering some of the questions from the attendees. So I would like to thank everyone for attending our morning breakfast at UM, all right, to actually improve our knowledge on updates on medical knowledge. I would like to thank everyone, Dr. Kong, and also the organizer. Thank you, everyone.
Thank you, everyone, for listening. Okay, and allow us to share our experience. Thank you.